So we'll just go quickly through some of the technique and the way that the MRI referral cases are run at Rossdales. So the first thing is to say that a good MRI technique starts at the beginning. So our horses are always allowed to go and stand in the box, accommodate to their surroundings, realise they're in a different place and settle down. Some of the race horses, they want them in and out, you know, in the middle of the night so that no one knows they're coming in. But taking them into the scan room just off the box, they're too agitated, they can't relax, they might need to urinate, and they don't like to do that in the MRI room. So we put them in the stable, we give them a little bit of time to relax, and then you've got a much calmer patient to try and interact with when you get to the MRI room. It's important that we see the feet and evaluate the feet. I think some people think that MRI is a sort of separate thing that gives you all of the answers, but it certainly isn't. And having information about the shoe that this horse is wearing, the trimming, the balance, any distortion in the coronary band is very, very important for how you're going to interpret all those things you're going to see on the MRI. Clinical examination, again, it's really important to have a connect between the images and that horse. It's always very, very important that we keep that connection there. And looking at the horse, so again, it's important that when you're faced with the images, you can also see how that lameness pattern was on the day that you did the scan. Not every practice does, but we always do a radiograph, so it's sometimes an unexpected cost for the client that we need to do a couple of x-rays just to check that there's no clench fragments in the hoof wall. These can have huge artifacts on the images, and obviously there's a charge for us doing that, but that's very important that we prep the feet in that way to make sure that the images are as beautiful as we want them to be. Sedation is very, very, very important, and there are practices. Everybody's got their own different way of doing it, and I'm sure that you guys here will go through a whole different set of things before you settle on what works for you. The mainstay of my sedation technique is Ramifidine. Everything gets about 2 mils, and then very small top-ups with Dom and Torb after that. I don't give them an infusion or anything. This is all off the needle, and some of that is just a time issue, really. And then in the scan room, obviously that's where all the critical action goes on. Actually, this is a picture of me, but there's the 2 girls that work with me do the majority of the scanning, and they're excellent at achieving what we need from that from that part of the technique. We need a comprehensive set of high quality sequences, obviously in the area of interest and in a reasonable time. And there are many factors that affect what sequences are achievable on that individual horse, and that's important. Not every MRI scan is the same. You can't achieve the same detail on some horses because of a whole different number of things. So it's important that we tailor the scan for that horse so that we get as much information out of it as we can. So the pulse sequences, there are obviously a basic set of pulse sequences that we need to acquire. Some of them are designed for us to look at anatomical structures, such as the T1 on the top left there. Some of them are designed for us to look at fluid, where fluid should not be, such as the T2 star and the stir on the bottom there. And then the T2 Faspinecco on the bottom left here, that has excellent contrast between the ligamentous tissues, and that's again very good at looking at the ligamentous tissues within the foot. So we need to get a combination of all of these pulse sequences in multiple orthogonal planes, and that's where you can go crazy, because the world is your oyster as far as orthogonal planes are concerned. There's obviously a standard set that we try and achieve, but you can do as many lesion orientated obliques as you wish. And that will depend on how busy you are that day as well. But it's important that you try and evaluate as many of the structures as you can, and that isn't possible just by doing a few different sequences. The foot is very complicated, everything's running in a different direction and turning corners, and it's important that we do a very dynamic process by following different structures as we see where problems may occur. There are particular areas where we need detail, and I mean anatomic detail by that, such as this is top left here, this is a very small dorsal margin lesion on the deep distal flexor tendon. The top right there are 2 little distal border fragments on a navicular bone. Distal border fragments are the new black. They are once thought to be very underwhelming, and now they're back in fashion, and we know that they correlate quite well with the general health of the navicular bone. So we no longer necessarily just ignore those when we see them on x-ray, but you need to look carefully for them. It's not that easy. The flexor cortex, Again, we've gone from looking at end-stage flexor cortex ulceration to these very fine little areas of fluid accumulation on the flexor cortex, signalling early pathology, and the coffin joint cartilage, and also fibrocartilage on the back of the navicular bone. But we need detail, good anatomic detail to look at cartilage. And as I've said already, there are a host of different ways to achieve this in the best way. Hallmark have worked very hard to give us almost too long a list actually of sequences that we are capable of acquiring. And again, it's important that whoever's pressing the buttons knows exactly why and when and how to use these sequences. So interpretation, just a little bit about as far as reporting goes, there is quite a difference between a radiology report and a sort of logical interpretation in light of all the information, and that's a little bit what we're trying to stress today, is that information about the foot, the blocks, the lameness history, the MRI images, and then going on to take the case forward is very important. So if I report for a case that I've never laid eyes on and have had very little information about, then it gets all a little bit technical, it's boxes and it's bullet points and there's no images because they weren't mine, so I couldn't necessarily, put them on there and put arrows on them. There is a trend towards slightly defensive radiology reporting under these circumstances. When we have more information about the case, when we've been able to communicate well with the referring vets or with the other sites that I read for, when I've been able to see the horse myself or see the radiographs and this type of thing, we get something that you can use a little bit more logically. So this is a MRI report for a horse that's got a little crack in its condyle, and these particular types of cases where we're looking for things like condylar fractures, it's super important that we have all this information to make the right decisions about that horse. So reporting morphs a little bit depending on what information that we have, and that's been stressed already. So communication, I've spoken a little bit about that already as far as the referral clinician, radiologist reporting the images, but client communication, I think this procedure either succeeds or fails with how we sell it to the client and how we talk to them and how we make them understand it or how we tweak their understandings of it a little bit. And they need to know at the time that they make the booking what to expect when they arrive. So people that turn up and expect it's going to take an hour and they'll be on the road again, that does happen if there's a breakdown of communication. They go away dissatisfied because their day's been ruined, they've got to book another day off work to come and collect it tomorrow. And getting a good systematic way of talking to your clients before they arrive. So when you guys are saying, well, we're going to send you for an MRI scan, expect it to stay overnight, don't expect to get the results the same day, then they're fine with that as long as they know that before they go put the horse in the trailer and get to you. It's very, very important to do that. And again, when we admit them for an MRI scan, I spend a lot of time talking to them about all the things we've already said, why it might not work. It's important, I think, to remember that the clients see this as the gold standard, and quite rightly so in many circumstances. They do see it as the gold standard, but sometimes what they take from that is that this is absolutely infallible, that we're going to take the horse, they're going to spend an hour with it, we're going to walk out and everything will be illuminated. And that's not necessarily the case. And so I think it's important that what we do is align the client's expectations with our own to make sure that those two things are identical. So it isn't a gold standard. We won't be getting 100% sensitivity and specificity, but it is a gold standard in the way that phrase is used in medicine, in that it's the best technique available for us under reasonable conditions. So if we don't want to anaesthetise your horse, then the gold standard is a standing MRI scan. So we have to align the client's expectations with ours. And then afterwards, after the MRI scan, it's important that we communicate back to them in language that they do understand, because we get very excited about all the things that we see on the MRI scan, and it's this and it's that. They basically want to hear the words, is it navicular syndrome? Is it osteoarthritis? Has it got a ligament injury? Has it got a tendon injury? And although it's important to record all the things that we might see, because they may be relevant at some point, it's important to pick out those things that the client will take home and have an understanding of. And I think if we and not to talk down to them, but if we get too complicated, you sort of lose them as what have we actually achieved. So it's very important that we tell them and enable them to go home with something that they were sort of expecting, that these diseases have always existed and we now look at them in a different way, but we have to sort of keep the client on board with what's going on. So clinical experience, we'll just talk a little bit about that. Well, as far as this system goes, we'll just start there. There are some problems with it which are usually surmountable, but there are some problems with motion that we've spoken about. The slice thickness can sometimes be a problem. We have to work very hard to get the slices as thin as we can to make sure that we get as much resolution as we can. And as Jonathan has already said, the field of view is smaller than a high field system or a CT scan is possible. So we need to accept that we need to be very sure of where we're looking and the types of things that we're looking for. But the system has progressed hugely, so the problems that we've had in the early days have now almost all been resolved by Hallmark, who have been excellent at working on the system and optimising it for us. We're now able to get lovely pictures in the majority of cases, in the majority of areas of the distal limb. We can get cartilage imaging very, very nicely. I'll show you a little bit later. There's still some issues with it, but if you look carefully, you can make very good judgments about that. And we've got things like the cost is potentially lower, the potential for follow-up is better, so if we want to check out if that lesion's healing, we can do that much more easily than perhaps we could if it required another anaesthetic, and we can scan close to competition. So as long as you're careful with your stations, you can scan quite close to competition, and obviously as well horses in training and this type of thing.